Thank you for joining my presentation on predictors of extubation failure. In the care of critical ill patients, mechanical ventilation offers an essential support during recovery from acute respiratory failure. Weaning off the ventilator and removing of the endotracheal tube can account for as much as 40% of the total patient's time on mechanical ventilation. Patients who are on a ventilator for an extended period of time are at risk for ventilator-associated pneumonia, lung injury, airway trauma, and death from complications of invasive mechanical ventilation. My name is Terrence Shenfield, and I've been an education coordinator at a major trauma center for 30 years, and I hope you really enjoy this presentation. I also am the co-owner of A&T Respiratory Lectures. So what exactly is extubation failure? Extubation failure can be defined as reintubation within 24 to 48 hours of a planned extubation. It occurs typically anywhere from 10 to 20%, but can vary with a patient's population. In most times, patients who come off mechanical ventilation have weakened diaphragms. They can also have retained secretions. They could also be neurologically impaired, that they're not really doing a great job of supporting their ventilation. So there's a bunch of different reasons why we have extubation failure. It also depends on the population. Certain populations of patients wean off the ventilator much quicker than others. So we're going to be talking about different populations who are on mechanical ventilation, how to wean them, and what we can do to ensure their weaning success. In the perfect world, when we intubate somebody and then extubate them when they recover, it should be a clean thing. Basically, we intubate them, we maintain them on mechanical ventilation, we wean them, and they're fine. But that's not always the case. Like I said on the previous slide, about 20% of all patients who are intubated, who become extubated, need to be reintubated. So reintubation rate is really something that you need to consider. Why is it happening? Studies have shown that if you reintubate somebody, there's an increase in duration of mechanical ventilation. Those patients stay on the ventilator longer than the average person. Also, the longer you're on mechanical ventilation, the greater your length of stay. The greater you're on mechanical ventilation in an ICU, the greater likelihood that you're going to require some kind of nosocomial infection. All of this leads to increased mortality. Also, the longer you're on a ventilator, and especially those who have failed extubation attempts, they're going to typically be trached. So all of these complications are a result of extubation failure. So at the end of this presentation, I'm going to talk about ways to ensure that the patient who comes off the ventilator stays off the ventilator. But all of these things you need to keep in mind, because these are real things that happen in the ICU every day. So you have a patient in your ICU who is intubated, and you're ready to take them off the ventilator. So you're assessing whether they would be a good candidate to come off the ventilator. Some of the things you got to consider: the longer a patient is on a ventilator, the greater likelihood they have some form of diaphragmatic weakness. There's a term called ventilator-induced diaphragmatic dysfunction, or VIDD. What that means is when patients who are on mechanical ventilation for an extended period of time, and you offer them some kind of assist control or CMV type of mode, and they don't breathe above the vent, the diaphragm, which is a muscle, weakens and atrophies. As a result of that, so the longer you have a patient on a ventilator, the greater likelihood they're going to fail due to diaphragmatic weakness. And what that means, they're not going to be able to mobilize secretions, their inspiratory capacity is going to be really bad, so they're going to really not do too well. Another group of concern is left ventricular dysfunction. A lot of patients who are intubated, especially elderly patients, have some kind of left ventricular dysfunction. And studies have shown that if you happen to have any kind of cardiac abnormality, you're at greater risk of an extubation. Another group, older patients. The older you get, the more difficult it is to come off the ventilator. A lot of these patients are COPDers. A lot of patients have comorbidities and a whole host of other things going on with them. Also, a lot of patients, the longer you're on a ventilator, the greater likelihood you're going to have upper airway obstruction. Upper airway obstruction, inflammation, can be readily determined by just deflating the cuff and listening for air to escape around the endotracheal tube. Also, as a result of diaphragmatic weakness and muscle weakness, they might have an ineffective clearance of respiratory secretions. That is a big reason why patients fail mechanical ventilation. They just can't cough effectively and they drown in their own secretions. Another thing you might want to look at, when someone comes into the ICU, there is what they call Apache scores and SAPS2 scores, and typically respiratory therapists and nurses really don't pay attention to this. But basically, this is a scoring system that determines how ill this patient is. So if someone comes in to the emergency room because they have a COPD exacerbation and resulted in intubation, if they have diabetes, if they're elderly, if they have other comorbidities, that would increase the Apache score to SAPS2 score. So sometimes it all depends on how ill you are and what kind of comorbidities you have. Like I said before, prolonged mechanical ventilation, the longer you're on a ventilator, the likelihood that you might get a ventilator-associated pneumonia. You also have diaphragmatic weakness. And a lot of these patients have, because of sedation on board, and they need sedation. When you're in an ICU, you definitely need some kind of sedation on board. But a lot of them show neurologic impairment. And some studies have shown that if you get a blood gas prior to extubation and the PCO2 is greater than 44 millimeters of mercury, there's a greater likelihood that you may fail that extubation attempt. So these are some of the risk factors you want to look at prior to extubating the patient. So we decide to extubate the patient. We put them on some kind of oxygen support while they're being extubated, and shortly we have to reintubate them. So the question is, why does this happen? Why do we have to reintubate them? I talked about the risk factors in the previous slide, and some of the reasons why people are reintubated is there's an increased work of breathing. So what do I mean by increased work of breathing? When someone is extubated and their respiratory reserve due to the weakened diaphragm and the patient hyperventilates, they're just trying to breathe in, but they're not getting good deep breaths, and eventually they tire out. Also, there's a use of accessory muscles use. There's, different types of muscles involved with breathing. For example, in the inspiratory cycle, you got the sternocleidomastoids, you have the scalenes, you have the pectoralis major, you have all of these different muscle groups that could become weak. And in regard to expiration, in regard to muscles that are part of the expiratory cycle, you have the rectus abdominis, which is your stomach, you have external and internal obliques, and you also have internal intercostals. What that means is if you're using those muscles to support ventilation, you're on the road to failure. Also, a lot of these patients, because of this muscle weakness, they end up becoming hypoxic or they get hypercapnia. Hypercapnia means that they retain too much CO2 because they're not getting adequate ventilation. A lot of these patients, as much as we know to check to see if there's a leak around the endotracheal tube by deflating the cuff, a lot of them have upper airway edema. I've seen this many times, and this is when you give the patient racemic epi and you're trying to, decrease that inflammation. A lot of times these patients have inadequate muscle strength and most likely with glottic incompetence. Basically, they can't close their glottis to get a good deep breath to cough. They have excessive secretions. And many of these patients fail because of residual effects of sedatives. What do I mean by residual effects of sedatives? If someone's on Diprivan or if someone's on any other type of sedation medications, or morphine, and they've been taking these sedatives and pain medications for a while, a lot of times they store in the fat deposits of our body, and what happens is they're extubated and then they're released and they're still sedated. That's why a lot of times you really want to know what the RASS score. RASS score is a Richmond Agitation Sedation Scale. You want to see if they're fully awake, and a lot of these patients have depressed mental status. So in other words, you ask them to follow commands and they don't really follow commands. I've seen patients who they extubated, you sometimes give me a thumbs up, or lift your head above the pillow, and if they can't do that, they're at greater risk of failing an extubation attempt. So these are some of the reasons why patients fail an extubation, and then what happens is we have to reintubate them. So as respiratory therapists, I'm sure you understand extubation criteria. This is when we determine whether a patient is ready to come off the ventilator. And some of these things are old news for you. For example, you got to make sure that their vital signs such as heart rate, blood pressure, saturations are all good. You also have to make sure that their underlying medical condition improves. So in other words, when they're admitted into the hospital, you want to make sure that whatever medical condition they came in that required intubation is resolved. So if that's resolved, and then you look at lung mechanics. Lung mechanics could be compliance, it could be resistance. It all depends on what kind of patient you have. You can look at your NIF, your negative inspiratory force. Typically we use for minus 25 or 30. You want to get gas exchange. Well, how do you measure gas exchange? You do a blood gas. You make sure the blood gas is good and everything looks good. Then you could commonly use what is known as the rapid shallow breathing index, which is basically an equation of frequency over tidal volume. From my experience, we used to look for a RSBI less than 105, but from the literature, many patients who had a good RSBI failed. Some studies show that you need to have an RSBI less than 65, but I really honestly think I was looking for patients in my time that had an RSBI less than 65, and I really didn't see that too much occur. Another thing you want to look at is Apache scores and SAPS2 scores. And I was telling you a little about that before. That's a measure of the severity of your illness. And I think I'm going to get a little bit more into it a little bit later, but basically, when a patient's admitted into the hospital for any kind of medical condition, they give them an Apache score or SAPS2 score. Now, what that means is if you have someone who's admitted to the hospital who happens to have, say, exacerbation of COPD, for example, and they are a 55-year-old person, and otherwise, besides their COPD, they're pretty healthy, they would have one set of Apache scores or SAPS2 score. Now, if you get another patient who comes in for the same diagnosis, but instead of being 50, they're still 55, but they have congestive heart failure, they have hypertension, they got diabetes, their SAPS2 score or their Apache score will be much higher because they have a lot of comorbidities. Studies have shown that if you know what some of the Apache scores or SAPS2 scores upon admission, you could do a better gauge of seeing if they're a good wean or something. So I'm going to tell you more about that as we go along. When you think about weaning the patients from mechanical ventilation, not all patients are the same. I'm sure you could all relate to this. My mom happened to be a COPD. She broke her hip. She was intubated. She was the most difficult wean you can imagine. I've seen other COPDers who are difficult weans. Then I've seen cardiac patients who come in, they get open heart surgery, and they're extubated 2 days later. I've seen surgical intensive care patients, and I've seen medical patients who can sometimes be an easy wean and sometimes not. So the point what I'm trying to say, of all these groups of patients who are weaned from mechanical ventilation, the two groups that represent the biggest problem are the COPDs and the neurosurgical patients. In my hospital, we worked at a major trauma center. We had a neurosurgical unit, And a lot of those patients were very difficult to wean. And in fact, we had weaning protocols throughout the hospital, but the neurosurgical fellows did not want us to wean the patient for a few reasons. And I'm going to get a little bit more into that, but the point I'm trying to say is not all patients wean the same way. And when you talk about COPD patients and you talk about neurosurgical patients, they are a different type of wean, and you should know about it. I'm going to get into some more details about that. But surgical patients, cardiac patients, medical patients are all typically similar weans. But you got to watch those COPDers and you got to watch those neurosurgical patients. Today's presentation is talking about predictors of extubation failure. And I wanted to talk about the two populations of patients who are difficult weans and happens to be the highest percentage of extubation failures, namely the COPDers and the neurosurgical patients. So this next few slides, I'm going to be talking about COPDers, and I found a very good study. Even though it's from 2006, it seems dated, it's still very good. It's still relative to what's going on. And the title of that presentation was called Predictors of Extubation Failure in Patients with Chronic Obstructive Pulmonary Disease. As I was elaborating earlier, understanding someone's SAPS2 score or their Apache scores is very important. And why is it very important? Because you could determine it's a predictor of extubation failure. This whole topic is about extubation failure, picking the right population, the right patient. But if you really wanted to look at somebody, you got to look a little bit deeper. And one of the most important scores out there is called a SAPS2 score, which is a new simplified acute physiology score. This is collected on the first day of admission. Within the first 24 hours, they look at this data. So, for example, someone comes into the hospital, they're 60 years old. They're admitted for appendicitis. They look to see if they have any kind of chronic diseases, like they have COPD, or if they're, if they have hypertension, or if they have kidney disease, or whatever. They also look at your Glasgow Coma Scale. They look at your age. They look at your vitals, like your blood pressure, your heart rate. They look at your body temperature. They also look to see if you have any history of mechanical ventilation or CPAP use. They look at your urine output. They look at your BUN, the WBCs, potassium, and so on and so on and so on. So based upon all these variables, they come up with an Apache score. So everyone, even if you have two patients admitted for appendicitis and both of them are intubated, but their Apache scores can be different because they don't follow the same pattern that is recognized here. Someone may or may not have chronic disease. Someone may be 27 and the other one is 65. So with all that being said, understanding your SAPS2 score on the date of admission is an important variable in determining whether they be a successful extubation or not. And I'm going to get more into this as we go along. So this is a chart that is how the SAPS2 score can be used in regard to mortality. Here's what you're talking about. This graph up here on the vertical axis right here from 0 to 100% calculates the predicted mortality of patients. This point right here on the horizontal axis points to the total points that were achieved during the SAPS2 score. So as you can see, your higher your score, you have a score of 0, the likelihood of your dying is 0. If you have a SAPS2 score of 20, the likelihood of you dying is like 5%. If your SAPS2 score is 40, your likelihood of dying is 20%. So what I'm showing to you, as your score gets higher and higher, and what makes a higher score? Those certain parameters that I just mentioned on the previous slide are indicative of higher mortality. So understanding someone's SAPS2 score predicts mortality, which is very important, but also it can predict extubation failure. So that's why this particular scoring system is so important to understand how someone is when they come into the hospital. To further talk about this study. When they did this study, it was from January 1996 to May 2002. It was a retrospective study. They looked at 148 patients who came in with COPD, and they were all intubated. As a result of those 148 patients who had COPD, 65% of them had successful extubations, 17% of them went on to non-invasive ventilation, and then the key point here, 18%, because we're talking about predictors of extubation failure, 18% of these people actually required reintubation. So what can we do to decrease those numbers? So let's look at some further characteristics of these patients. And remember, we're talking about COPD patients, and we're talking about predictors of extubation failure. So there are some common veins going along with this. First of all, a lot of COPDers, as they say, end up being on home mechanical ventilation. So one of the variables they looked at was the use of non-invasive ventilation at home. And they found that a lot of these patients who had COPD were on home mechanical ventilation or non-invasive ventilation. And also a very important part, they looked at that SAPS2 score. Remember I was telling you about the acuity score? And a lot of the people who were admitted in the ICU had an average SAPS2 score about 38%, 38.6%. So these are two variables you want to keep in mind, that the COPDers potentially may have been using non-invasive ventilation at home, and they also had a SAPS2 score that was increased. So I want you to keep that in mind. So in this population of 148 COPDers, and who was successfully extubated and who wasn't, I wanted to bring some highlights to you. First of all, this column right here talks about successful extubations, and this column right here talks about extubation failures. So what is the difference between the group that successfully extubated versus the group that did not extubate successfully? And some of the things were pretty even, that really didn't make any kind of statistical approach that it was really important. But certain things did stand out. For example, we've been talking about the SAPS2 score, right? And we've been also talking about the use of home non-invasive mechanical ventilation. And they found that the group that successfully got extubated really didn't use the approach too much. So most of the failures came with a SAPS2 score of over 42 versus the people who succeeded at 36. So if you know someone's SAPS2 score, it's relative to whether there'll be a successful extubation or not. And then another thing, most of the failures, 10 versus 3, were using non-invasive ventilation at home. So the takeaway from there is that if you happen to be on non-invasive ventilation at home, you are at a higher risk of extubation failure. And if your SAPS2 score was higher than 36 on the average, like in the 40s, like this one, you were more likely to have an extubation failure. So if you recognize these two variables as being important on weaning these patients, keep this in mind. And maybe there's some strategies you can wean them a little differently, or you got to be a little bit more careful, or you need to extubate them to non-invasive ventilation. I'm going to get a little bit more into this. Another variable that came into this equation was endotracheal culturings on extubation. What happened was you have extubation successes and you had extubation failures, right? And they found that patients who had a positive endotracheal aspirates for some kind of pathogen, this whole list down here, anyone who actually had some kind of growth in their airway was at a greater chance, like almost like 48% versus 23% of extubation failure. So besides the home mechanical ventilation, besides the SAPS2 score, when you have a positive endotracheal aspiration for any kind of pathogen, that increased the likelihood of failure. So we're going to get a little bit more into that too. So these patients who were weaned, 148 patients who were weaned, and a certain percentage of them failed extubation attempts, and they were looking to see why. What made them fail this extubation attempt? And the three things that jumped out was the use of home non-invasive ventilation, also a SAPS2 score greater than 35, and also if you had any kind of growth in your endotracheal tube based on aspirates, that was another sign of failure. Now, they use this term called adjusted odds ratio. What that means is the likelihood of failing versus a normal person. So, for example, of those 148 patients, the odds ratio for the use of non-invasive ventilation was 12.99. The odds ratio for SAPS2 score greater than 35 was 3.88, and sterile aspirates was 0.23. So the real take-home points are the non-invasive ventilation and SAPS2 score. So now we're at the slide where I'm going to make recommendations for when you wean a COPD patient. In the COPD population, extubation failure can occur up to 35%. If you extubate somebody and they fail and you reintubate them, their mortality can increase to around 9 to 15%. The patients who have a higher SAPS2 score or Apache score, which is demonstrated right here, typically require longer mechanical ventilation and actually are difficult weans and also have a greater risk factor for failing. So some of the predisposing facts you got to pay attention to is the use of non-invasive ventilation at home, a SAPS2 score of greater than 35, and positive culture and endotracheal aspirate within 72 hours. You want no growth. That's what you want. You don't want to see any kind of growth in the endotracheal tube. So keep this in mind. It will help you with weaning these patients. So let me go to the next slide because I want to further this. So other points you really want to take home on COPD patients. COPD patients typically have more secretion problems than your average person. So if you suction this person every 1 to 2 hours, the likelihood of failure is 8-fold. So sometimes you got to look like how many times are you suctioning this person? Are they being suctioned every 1 to 2 hours to mobilize secretions? The likelihood of them failing is really high. They have this test called the white card test, and my respiratory therapist brothers and sisters are going to love this. Basically, what you want to have someone do is you want to remove them from the vent and put some kind of white paper at the end of the endotracheal tube or the trach, and you're going to ask them to cough. You want them to mobilize secretions. So basically, you have this white card, you have an endotracheal tube that's open, and you have a trach that's open, and you ask them to cough up secretions onto the white paper. If they can cough on the white paper, they can mobilize their secretions. Another thing you really want to know about is a lot of patients, one of the good strategies for weaning an COPD patient is to extubate them to non-invasive ventilation, because a lot of times they're on non-invasive ventilation at home, so when you are weaning them, you can anticipate weaning them directly to NIV, and then you can wean them the other way. And then the other final point is this: if they have a SAPS2 score, which sometimes we don't really pay attention to, but if your SAPS2 score is greater than 35, then you know that they're going to possibly be a very difficult wean, and you really got to be careful how you wean them. With neurosurgical patients, retrospective and prospective investigations have documented increased rates of reintubation, pneumonia, tracheostomy, and prolonged mechanical ventilation with patients with acute brain injury. So bottom line, this population of patients are difficult weans, and some of the tools I'm going to show you later can help you get these patients off the ventilator. And they have a high degree of reintubation rates, which is not a good thing. As I was mentioning with the COPD patients, they are difficult weans. The good news is at the end of this presentation, I'm going to show you a method how to wean these patients that could greatly benefit you, especially in regard to COPDs and neurosurgical patients. So this next presentation, or the same presentations, we're going to talk about predictors of successful extubation in neurosurgical patients. Again, this study is from 2001. It's an old but goodie, and basically it was published in the American Journal of Respiratory Critical Care Medicine. So I'm going to show you predictors of successful extubations in neurosurgical patients and tools you could use. Now remember the last slides we were talking about SAPS2 Score. Another very important scoring system, which is very similar to the SAPS2, is called the Apache Score. And the Apache Score counts for acute physiology and chronic health evaluation. And what this is, it's a system for classifying patients in the intensive care unit for their severity of illness. And basically, you do this within the first 24 hours of the patient being admitted. And what you use, this is a great tool to estimate mortality. Now, the flip side to this is if someone has a high mortality rate based upon their Apache scores or the SAPS2 score, you could also guarantee that they will be a difficult wean from the mechanical ventilation and the likelihood they would fail that extubation attempt. So understanding Apache scores and understanding SAPS2 scores is really important. So that's why I keep on drilling this to you. Now I wanted to show you the scoring system for Apache scores, kind of similar to the SAPS2 scores. They look at cardiovascular variables. What's cardiovascular? Heart rate, blood pressure. They'll be looking for all kinds of things like that. Also, they'll look at respiratory components. They'll look at respiratory rate. They'll look at your tidal volumes. They'll look at all these other parameters. They'll look at renal values like creatinine. They'll look at gastrointestinal valuables, including abdominal distension. They'll look at hematologic values such as WBCs or hematocrit. They'll look to see if you're septic, if you have any kind of multi-organ dysfunction syndrome. They'll look at metabolic variables, potassium, sodium, and so on. Again, they'll look at the Glasgow Coma Scale. This is really important, the Glasgow Coma Scale with the neurological patients. And this is something when I was speaking to the residents and the fellows from the neuro ICU, they say on your normal weaning protocol, you do not incorporate the Glasgow Coma Scale into your program. And it says we do. So that was like a little eye-opener, but I'm going to continue with this. So understand the Apache score is like the SAPS2 score. You look at the date of admission of the patient into the ICU, you add up all these variables, and you come up with a number. So with the Apache score, you have the probability of death in the hospital based on these scores. Now, the correlation between mortality and extubation failure is hand in hand. If someone has a high mortality rate, they're going to be a difficult wean, and the likelihood of them being reintubated is greater. So, for example, with the Apache scores we have right here, if your score is 0 to 5, you have a 2.3% chance of dying. That means you're going to be a great extubation. You're not going to be difficult at all. If your score is 6 to 10, you have a 4.3%. If your score is 16 to 20, you have a 16%. So the problem is, as your score gets higher, as your Apache score gets higher, the likelihood of your mortality increases, but at the same time, the likelihood of you being a difficult wean and extubation and the likelihood that you might be reintubated is increasing too. So understanding Apache scores and SAPS2 scores, it should be part of the equation. So again, we're going to visit the Glasgow Coma Scale. I think the last time I had to visit the Glasgow Coma Scale before I did this presentation was probably in school. But after I had a good talk with the fellows from our neurosurgical intensive care unit, and after speaking to them on what criteria they use for neurosurgical patients, because I wanted to wean those patients. I wanted respiratory to get involved with them. So understanding the Glasgow Coma Scale is really important. And, you know, some of the basic things is eye-opening, verbal response, and sometimes if someone's intubated, they can't give a verbal response, but they can give you a thumbs up. Best motor response, pick your head off the pillow. Give me 2 thumbs up. But if you have any of these other scores, as you can see, if your eyes are open and they're spontaneous, you get a very high score of 4. If someone says to you, "Are you okay?" and you shake your head, "Yes, I'm okay. Do you know where you are?" and they say yes, you get a score of 5. But if someone says, you know, you tell them to, you know, give me a thumbs up, and they don't give you, they give you the finger, they still get a 6. You know, the point, what I'm trying to say to you, if you respond appropriately, your score is going to be high, and that's a good thing. The higher the Glasgow Coma Scale, the better off you are. But if you don't respond to anything, you're going to have a very low score. And neurosurgical patients are predisposed to low Glasgow Coma Scales, which is part of the reason they fail. So let me give you some studies of patients with Glasgow Coma Scales. If your Glasgow Coma Scale is less than or equal to 8, you're in pretty bad shape. If your Glasgow Coma Scale is anywhere from 9 to 12, you're in moderate shape. And if your Glasgow Coma Scale is greater than 13, you're in good shape. So understanding Glasgow Coma Scale is very, very important, especially with this population of neurosurgical patients. And we'll get a little bit more into that later. So another very important factor about weaning patients is the sedation they're on. They could be on Diprivan, they could be on lorazepam, they could be on any other type of sedation medication. They could also be on pain medication. So a lot of people don't respond appropriately, especially when you're trying to wean them. So a RASS score is called the Richmond Agitation Sedation Scale. And basically it is used by nurses to determine what level of consciousness the patients are. So perfectly, we want someone who's in a 0. 0 means they're alert and calm, and that means you could shut off someone's sedation like an hour beforehand, and now their sedation is off and they want to get the tube out of their mouth and they want to just like be extubated, and they're alert and calm, they're giving you thumbs up. So that's a perfect score. Typically, when your score starts going to a plus field, the higher the score, the more combative you are. Obviously, a +4, you know, you're off the charts. You are, you know, bucking the vent. You are going crazy. Now, if you get someone who's like a -5, you know, you say, hey, wake up, pick up your head. They don't respond to you at all. So why are people in this scores? I mean, there could be a lot of reasons, but from a sedation point of view, you want the sedation titrated off, that they are anywhere from a -1 to a +1. And why this is important? This is ultimately important for weaning patients, because you need to have someone who's somewhat alert and calm. They can be a little drowsy, they can be a little bit anxious, but they can't be off the wall, and they cannot be in deep sedation with no response at all. So RASS scores are perfect for weaning patients, especially who are on medication or sedation medication. I have a question for you. Whenever you were weaning patients, did you ever hear someone say, let's not wean this patient till they are awake, that they're not awake and responding appropriately? I must have heard this 1,000 times in my day. Now, with the neurosurgical patients, the ones especially with low Glasgow Coma Scales, the literature does not support the concept of delaying extubation with impaired neurologic status as the sole reason for prolonging intubation. So what this is saying is most of the research out there doesn't support the concept that the patient needs to be awake, especially with the neurologic patients, before you extubate. This is a key factor because a lot of physicians feel tensive about extubating somebody who is not fully awake and responding. but the literature doesn't support that. So I just wanted you to be aware of this. So in this particular study of their neurosurgical patients who are a difficult wean and reintubation numbers are really high, they did a randomized controlled trial where the primary outcomes included overall duration of mechanical ventilation, length of ICU stay, and time to successful extubation. So this was an extubation study for neuro patients, and let's continue. Secondary outcomes were, most importantly, reintubation rates, self-extubation, need for tracheostomy, mechanical ventilation days exceeding 21 days, cost of mechanical ventilations, length of stay, and mortality. So they were looking at a bunch of different things with this study, but in particular, we're looking at reintubation rates because patients who are reintubated, the mortality goes much higher with this group of patients. So what can we do to ensure that when we do extubate them, that they are good and they're going to stay off the ventilator? All this slide tells you is that this was a very well-balanced study between the intervention group and the control group, so there was no significant differences between them. So they did a very good job of randomizing this trial. This table shows you the number of patients who were on mechanical ventilation. They're in the neurosurgical unit, and the differences between the intervention group and the control group, for everything being said, they were a pretty controlled group. This is a well-balanced study. Nothing really jumps out at you over this. The findings from this study were quite interesting. For example, respiratory care practitioners performed a spontaneous breathing trial on 99% of the patients. So 199 of 201 patients in the neurosurgical unit ended up being on SBTs. What happened was extubation was only for about 25% of those patients who passed the SBT. So in other words, a certain percentage of those patients passed the SBT, everything was fine, but only 25% of them were extubated. So the question is, if someone passes an SBT, a spontaneous breathing trial, why are they not extubated? Why were they maintained on mechanical ventilation? And that's a really good question. So they asked the physicians, why did you not extubate them? They passed the SBT. Why are you not extubating them? Because only 25% of them actually got extubated. And the primary reason was the patient's level of consciousness. They wanted to perform a tracheostomy on the patient, and they had other reasons. But remember with the previous slide that all the literature goes against the fact that you should not hold back extubation based on level of consciousness, yet 84% of the cases for withholding extubation was due for that very reason when their respiratory mechanics were perfect. In other words, they passed the SBT, but because their level of consciousness was not that good, they decided not to extubate them, and that sort of went against the research out there on this topic. So when you look at the factors associated with successful extubation, what they did, all those patients who were finally extubated in the neurosurgical unit and those who required intubation versus those who did well with extubation, they found certain things that stuck out that made the patient more successful to be extubated. And some of the key findings were this. If your rapid shallow breathing index was less than 105, this was a great sign that you would have a successful extubation. If the PF ratio, that's your PaO2 over FiO2, was greater than 200, that was a great reason. If your Glasgow Coma Scale was greater than 8, that's a good reason. And then, they did some other studies where they combined the PF ratio, the Glasgow Coma Scale, and the RSBI. So the point is the top three are really, really important. So in other words, if you are in the neurosurgical unit and you're extubating these patients who are typically difficult and typically require reintubation, these are the things you want to look at. You want to look at your RSBI. You want it to be less than 105. You want to look at your PF ratio, which you want greater than 200. And very importantly, you want to look at the Glasgow Coma Scale to be greater than 8. The top two are things we look at as respiratory therapists. But I think on the most part, we really don't incorporate the Glasgow Coma Scale in our weaning practice. I learned this when I worked at my hospital when I was trying to develop a weaning protocol for this particular unit, and the fellows in the unit and the attendings all wanted me to incorporate the Glasgow Coma Scale. And that's where the evidence is. So, they were basing this on where the evidence is. So remember these three factors. So this is a summary slide when you look at what is associated with a successful extubation in this group. And these are the take-home points. Number one, you want your Glasgow Coma Scale to be greater than 8. That means the greater likelihood they will have a successful extubation. You want a higher PF ratio. You want a lower minute ventilation. You want your RSBI to be less than 105. So, but the point is this is not always the case, right? So there are times when, you try to do the best you can, but your Glasgow Coma Scale is 5. Your PF ratio is not that good. Your minute ventilation is a little bit high. So what do? And you also have your COPD patients. Some of them just don't fit the ticket. Everything I mentioned earlier about successful extubations on COPD patients can be questionable. So I want to show you a method. When you have a patient who doesn't fit into this guideline, what can you do? So factors, again, associated with a successful extubation, the most important factor is Glasgow Coma Scale greater than 8. So the odds of a successful extubation increase 30% with every increment of a Glasgow Coma Scale. So what that means is if you had in a Glasgow Coma Scale of 9, it was good. But if you had a Glasgow Coma Scale of 10, you had a 30% increase of extubation success. If you had a Glasgow Coma Scale greater than 8, you typically had a 75% success rate. But if you had a Glasgow Coma Scale less than 8, the success rate was 36%. So I want to show you techniques a little bit later. When you have a Glasgow Coma Scale less than 8, where the success rate of extubation is 36%, what do? And I'm going to show you that a little bit later. So when you look at this chart, this is a chart of successful extubations in relationship to Glasgow Coma Scale. So the Glasgow Coma Scales are on the bottom. We have a Glasgow Coma 3, 4, 5, and all the way up to 11, 10 and 11. And you notice that patients with the most successful extubations fall into this realm right around here. You know what I mean? Like this is where they're. So when you're at a Glasgow Coma Scale between 8 and 10, you have a really high success rate of being a successful extubation. And they did this. They did studies of thousands of patients, and they found that this was the most key factor in regard to successful extubations in this group. So my take-home message in neurosurgical patients when you're weaning them, incorporate the Glasgow Coma Scale into your weaning practice. And if you do, you will have a better likelihood of success versus not incorporating it. Also, the attendings and the fellows in the neurosurgical unit will be impressed by your knowledge to incorporate that into the weaning protocols, because we don't really think about that. You really think about Glasgow Coma Scales and other themes like, babies and, trauma and things like that. But think about these kind of things when you wean patients. So, moving forward, I'm going to show you some real good tricks. So you have someone who you're afraid to extubate because they failed, they are a neurosurgical patient or they're a bad COPD. things are just not picture perfect. What do you do? So as I was mentioning earlier, the COPD population and the neurosurgical patients represent the greatest challenges to weaning the patient, and they are the most likely that will require reintubation, and you know the negative aspects of reintubation. So if you have someone who's on the borderline, you're really not sure, there's a test, and this test requires you not to extubate the patient. So this tool or test is done with the patient on mechanical ventilation. You do not have to extubate them, and if they pass this test, they have a greater likelihood of a successful extubation. So the name of this process is called the early phase of minute ventilation recovery curve predicts extubation failure better than the minute ventilation recovery time. And this study was done, it was published in Chest in 2007, and it's just as relative today. You know, just when something works, it works. So I'm going to tell you more about this study. Remember, when would you use this tool? When you're not sure about a patient being extubated, they failed an extubation attempt already, you're just not quite sure. The Glasgow Coma Scale is low, they may have some extra secretion. There's a whole host of things that goes along why you'd be a little bit tentative about extubating them. So let me continue. So this is the basics of this study. Think about this. I'm going to give you a scenario, and then we're going to go into it. If you are testing, if I wanted to test your fitness level, like yours, the people I'm talking to, me, or if you want to test my fitness level, one of the ways of doing it, if I took a baseline pulse rate of me, and I put my hand on my pulse, and I check my heart rate, and my heart rate's 80. So then what I do is I do 20 push-ups, and then I run 20 yards and come back, do another 20 push-ups, run 20 yards, come back, do another 20 push-ups, run 20 yards, come back. Then I check my pulse. Now, instead of my pulse being 80, now it's 110. Why is it 110? Because I just worked hard. I just did a bunch of exercises. And as a result of the exercises, my heart rate went up, which is a normal response, you know. With the more exercise you do, your heart rate goes up. Now, the key point here is my recovery rate. In other words, how long does it take after I finish that exercising and running that my heart rate goes back to baseline, which is 80. The quicker it goes down to baseline, the better shape I am in. So if you understand this concept of you push the body to a certain level, you get your baseline pulse, you push your body to a certain level with some exercises, your heart rate goes up. How quickly, how many minutes does it take for your heart rate to come back to normal depends on how fit you are. It's same thing works with this process. So what you do is you look at the minute ventilation of a patient on mechanical ventilation. They call that the pre-SBT. Before you do a spontaneous breathing trial, you look at the minute ventilation. Suppose the minute ventilation is 6 liters. And then and they're on a pressure support of 10, for example. So they're on a pressure support of 10, right? And they're on they have a minute ventilation of 6. And then what you do, you take the pressure support and you turn it down to 0. When you turn that pressure support down to 0, that means the patient has to work harder to do their minute ventilation. So what happens is typically the minute ventilation will increase. It'll increase because they got more work of breathing to do. And you let them do this for about 20 minutes, and they're tugging along, and they're working harder and harder and harder. And then what you do, the key point, you put the pressure support back to 10. And then you wait. How long does it take them to get back their minute ventilation to the baseline of 6? It's the same scenario I was talking to you earlier about, how fit you are. What you are, you're testing the respiratory fitness of the patient. You're looking at their capacity to breathe, their capacity to maintain a minute ventilation, their capacity to get back to pre-stressful times. So the trick is get your minute ventilation prior to turning off the pressure support. You turn the pressure support off for 20 minutes, and then what you do is you put your pressure support back, and you look at the changes in minute ventilation. I have a better graph on the next page to show you. So they analyzed the results of these studies, with patients, and they found a very strong predictor of extubation, successful extubations versus extubation failure was minute ventilation recovery. So what happens was the patients who did well, their minute ventilation really was lower, 5.4 to plus or minus 5.2, and the ones who failed had a higher minute ventilation, 14.5 plus or minus 9.7. And then they also looked for the change in minute ventilation over time, over minutes. So I wanted to just understand that the people who did more successful were the patients whose minute ventilations they recovered quicker. And let me show you the next slide. Okay, so you have patients. Let me show you what this means. You notice that the dark black line is successful extubation. The light gray line is failed extubations. And you can see the graph up here. The bottom part of this, so what you have is your pre-SBT. So what they do is they measured the minute ventilation with pressure support. So prior to being extubated, they are on a pressure support of 10 or 12, whatever they are. And their normal minute ventilation is around 11 liters right there. Now, they noticed that the patients who were successful had a lower minute ventilation than those who were unsuccessful. So the key point here is minute ventilation is kind of important when you calculate when someone's being extubated. So you have a pre-SBT with a pressure support of 12. Then what you do during the SBT time, what you do is you decrease the pressure support from whatever the value is to 0. When you decrease the pressure support, these patients got to work harder to breathe. And as they work harder, you see an increase, right? You see an increase in minute ventilation in both the successful group and the failure group. So what happens is after about 10 minutes, both groups are really chugging along with a minute ventilation anywhere from 12.5 to 14. So they're just breathing high, breathing high, breathing high. And then the trick is you don't even extubate them. You put them back on pressure support. And how quickly they come back to baseline. You see the bottom part, how quickly they came back to baseline within a few minutes, basically around 6 minutes. So if someone recovers within 6 minutes, they are a successful extubation. The problem is the patients who don't do well, their minute ventilation, like this light gray area right here, stays typically high for a long period of time. And if you try to extubate them, they're going to be the worst patients to extubate because they're going to require reintubation. So the trick is you look for the people who recover within 6 or 7 minutes. You know what I mean? And then and you could even go up to 10 minutes. But so you put the pressure support back, you let them recover, and if their minute ventilation comes back to baseline kind of quick within 6-7 minutes, they are a successful extubation. So as you can see, that minute ventilation process is a really good tool to use this, and you don't have to extubate them. You could use this on any patient. But some final remarks: make sure that the patient can mobilize secretions. Use the white card test to determine muscle strength and determine a good cough. Utilize the SAPS2 score and Apache scores in decision making. If you do weaning neurosurgical patients, incorporate the Glasgow Coma Scale and a RASS score into your practice. Also, make sure the patient doesn't have any kind of airway upper edema. If you have a patient who PCO2 is greater than 44 prior to extubation, you better watch out because they have a higher likelihood of failure. If you don't know what's going on with this patient is so fragile, you don't know what's going on, utilize the Hernandez tool that I just explained. This minute ventilation recovery tool can be done at the bedside. It causes no harm to the patient, and you can really understand it. And also, be careful when you're weaning with pressure support. A lot of people use pressure support at higher levels, you'd be better off using tube compensation with them rather than compensating with pressure support, because that could sometimes give you lower spontaneous PCO2 values than the other way. These are some handy little tools, and I think the most helpful tool is that Hernandez tool. This is a short list of references for this topic. You'll find minimum ventilation recovery tools out there. It's been studied and restudied, and I really hope you enjoyed this presentation, and I thank you for joining me.